Okay, good afternoon, everyone, and welcome to the Focus Neo webinar. Before we start, it's our pleasure to meet more than 1,250 members registered to our website, and in this session, several hundreds have more than 700 has been registered to the session too, from 62 countries, and we welcome you all, wherever you are, maybe it's good afternoon or good evening. And please note, by system default, your mic is mute and the video is disabled. And you can send your questions through Q&A, and the moderator will summarize your questions for you. And a kind reminder, please do not forget to fill out the feedback form to get your CME certificate. The link is sent by email. Please check your inbox, and the link will expire in 24 hours. It's my pleasure to introduce Dr. Ruben Alvaro. Many of you have seen him in past webinars. He's an associate professor and the director of St. Boniface NICU in Winnipeg, in University of Manitoba. It's our pleasure to invite him to moderate this session, and Dr. Ruben Alvaro.
Thank you, Gani. It is my pleasure to introduce Dr. Martin Keszle. Dr. Keszle was born in Prague, in Czech Republic. He is a professor of pediatrics at Brown University in Providence and the director of respiratory care services and associate director of nurseries at Women's and Infants Hospital in Rhode Island. Dr. Keszle obtained his medical degree from the McGill University in Montreal, and his pediatric as well as his neonatal perinatal medicine training at Children's Hospital Medical Center of Akron in Ohio. He then joined the faculty of Georgetown University in Washington, D.C., where he rose to the rank of professor before joining Brown University in 2010. Dr. Keszle has published over 200 original papers, review articles, book chapters, and editorials, and presented over 350 lectures in national and international conferences and seminars. Dr. Keszle is a clinical trialist whose research has focused on various conventional and unconventional means of respiratory support, including delivery room stabilization, non-invasive respiratory support, volume-targeted ventilation, high-frequency ventilation, ECMO, and inhaled nitric oxide. Today, Dr. Keszle is going to present on the physiology of neonatal volume-targeted ventilation, and we look forward to hear him speaking today. Welcome, Dr. Keszle.
So thank you very much. Thank you, Ruben, for that kind introduction, and thank you inviting me to present. How do we get my slides on the screen now?
Can you share? There is a
there we go. There we are. All right, and this is a new format for me. So, again, welcome. As you heard a moment ago, I was once a Canadian and very much wishing to be so again, given what's going on with our government. But that's another story. We're here to talk science and volume-targeted ventilation. So, let me begin. A few obvious points. We all have these wonderful devices in our hands, but they're simply tools. They don't by themselves make babies better. There's no machine that's inherently lung protective, no matter how sophisticated and wonderful the machine is. If we don't use it optimally, we're not going to get the optimal outcome. So with this premise, we'll talk about a lot of issues, specifically focusing on pathophysiology and how to address a particular So, of course, we're all interested in preventing lung injury in our very vulnerable preterm infants. They, of course, don't have true alveoli when they're born at 23 weeks, but the concept still holds in terms of how a healthy air exchanging unit can rapidly be injured in a complex process that involves some form of biophysical injury that triggers a cascade of events, starting with an influx of activated neutrophils, release of a variety of mediators and markers of lung injury, proteases, and all sorts of other things that will eventually initiate the process of lung injury and repair, and eventually lead to chronic lung disease. And so we cannot always control the other factors, but we do have some control over the biophysical type of injury. And I'll try to convince you that we should be more concerned about excessive lung stretch. And we'll talk about how to prevent some of those events from occurring. But I want to make the point in this particular slide to clarify that there are so many factors that impact on the eventual pulmonary outcome, starting already in utero, potentially with chorioamnionitis and initiation of the lung injury cascade even before the baby is born. But all items above the line are important contributors to lung injury. There's genetic predisposition. The events around the time of birth are critically important. The point of this slide is to emphasize that the pathophysiology is very much multifactorial, and that just taking care of one thing is not going to be sufficient, and it's not going to result in a dramatic improvement in eventual pulmonary outcome. It needs to be a bundle, a package deal. We need to pay attention to everything. Nutrition is critical. But today we'll focus on mechanical ventilation. And of course, the best way to avoid ventilator-associated lung injury is to avoid mechanical ventilation altogether, and most of us do a pretty good job of that. That will not be the focus today, but of course, there are some very immature infants and some very ill infants who still require mechanical ventilation despite our best efforts, and that's where we're going to focus today. So I'm going to get right to the point, which is that we have a fair amount of evidence that volume-targeted ventilation relative to pressure-controlled ventilation improves outcome. The evidence is not perfect because it includes a variety of small studies using different kinds of volume-targeted and volume-controlled ventilation. But nonetheless, getting to the punchline first, it did show a pretty dramatic reduction in BPD, as defined by the standard 36 weeks criteria, more than 25% reduction. The combined outcome of death or BPD just missed significance, but suggests the point estimate suggests a 25% reduction, but not quite statistically significant. All the other outcomes, in fact, are statistically significant. There's a quite dramatic reduction in severe intracranial hemorrhage. You can see more than 50% reduction in PVL or severe intraventricular hemorrhage, with a number needed to treat of around 11. Some dramatic reduction in pneumothorax and hypocapnia. So this is something we should mostly do, and I'm pleased to say that in Canada, most folks are using volume-targeted ventilation. South of the border, that is in the United States, we're lagging behind substantially, and it's still somewhat of a minority who have embraced this concept, and we'll get back to perhaps why. So what are the basic rationales for volume-targeted as opposed to pressure-controlled ventilation? Well, it turns out that although everybody's always talked about barotrauma, we should really worry about volutrauma, excessive tissue stretch, and I'll show you some evidence about that. I think you all know that inadvertent hyperventilation occurs frequently, and that hypocapnia is bad for the brain and also, of course, for the lungs when we're ventilating more aggressively than we need to. And I'll try to point out why adult type of volume-controlled ventilation doesn't quite work in newborns. We tried that 50 years ago, or 40 years ago anyway, and it didn't work so well for various reasons. So back to some basic evidence, and this is not new information. This has been around for a long time. But here is a study that took a bunch of small animals, exposed them to progressively higher inflation pressures, going up from 15 to 30 to 45 centimeters. And they looked at a marker of acute lung injury, capillary filtration coefficient, essentially lung edema, after a short period of a couple of hours of mechanical ventilation. And in one group, there was a plaster cast placed around the chest and abdomen, chest wall excursion and therefore tidal volume. So at 15 centimeters, nothing much happened because that does not overstretch the lungs. At 30 centimeters of pressure in these animals whose lungs had normal compliance, they were healthy lungs, there was already a significant increase in the capillary filtration coefficient, as seen here, but no change where the tidal volume was constrained. And it's not surprising that at 45 centimeters of pressure, which is way excessive, there was a dramatic increase in acute lung edema. What is surprising is that there was no such increase where the chest wall excursion was limited and therefore the tidal volume was not excessive. And what this tells us is that pressure exerts its injurious effect mediated by tissue stretch. And if that high pressure does not result in excessive tissue stretch, it does not cause acute lung injury. There are other studies showing much the same thing. Again, this was published more than 20 years ago. And here there were three groups of animals that were, and again, the investigators looked at markers of acute lung injury, essentially, again, lung edema and protein leak. And as before, where the lungs were free to expand normally, there was a lot of lung injury in the red bars here. Where there was a constraint placed around the chest and abdomen, in this case, a tight elastic bandage, there was a lot less lung injury. And in the third group in the middle, in yellow, were animals where the excessive tidal volume was generated through negative extrathoracic pressure. So removing the positive pressure factor, but maintaining the tissue stretch. And the bottom line is that regardless of whether the large tidal volume was generated with positive or negative pressure, it resulted in a great deal of lung injury. And that despite being exposed to the same high positive pressure as the red bars, when the chest wall was constrained and tidal volume was limited to a normal value, there was much less lung injury. So again, volutrauma rather than barotrauma would be appropriate. I don't know if everybody else can see there. I have something superimposed on the screen. Okay, I think I got rid of it. So let me then briefly talk about the basic fundamental differences in bond to changes in compliance depending on what the primary control variable is. We have traditionally in neonatology used pressure as the primary control variable, but in older patients, in the PICU and adult ICU generally, volume controlled ventilation is utilized. And when volume is the independent variable, when compliance increases, since volume is fixed, all that will happen is that the pressure needed to generate that, to deliver that tidal volume is simply going to be less. The volume is fixed. It's a primary control variable. But we don't typically do that or traditionally have not done that. We've used that pressure control. And when pressure is the independent variable, it is fixed. And when lung compliance increases, the tidal volume that is delivered with that same pressure now goes up. It could be a good thing if the tidal volume was inadequate to begin with, but if we've set sufficient pressure to deliver a normal tidal volume and then lung compliance improves dramatically after we give surfactant or recruit lung volume, we're going to potentially patient and we're going to overstretch the lung, resulting in lung injury. So it's important to keep in mind what is the primary control and what is the derived variable. Of course, we know that lung compliance changes, and we'll get back to that. So volume-controlled ventilation, I mentioned we tried to use early on. The problem with volume-controlled ventilation is that what is controlled is the volume delivered into the proximal end of the ventilator circuit over here. And that's all okay if you have a large patient whose lung volume is much larger than the circuit. There will always be some stretching of the elastic circuit and, more importantly, compression of gas within that circuit when you apply pressure. However, again, if the relative compliance of the patient's lungs is large, as in big patient, it's not a big problem. But when you attach a 600, 800 gram preterm infant to this circuit, and those babies' lungs are a fraction of the volume of the circuit and humidifier, the proportion of tidal volume lost to compression is greater. And then, of course, we have the problem with the uncuffed endotracheal tube, with the variable leakage around the endotracheal tube. You can, up to a point, compensate for the circuit compliance, and some devices have that provision to use an automated compliance compensation, but that completely breaks down when you have a leak around an uncuffed endotracheal tube. There are devices that are being used quite often in the United States, less so in Canada, because in Canada you have access to a variety of pediatric neonatal ventilators, whereas in the United States, thanks to our Food and Drug Administration, which keeps useful technologies away from our patients, we only really have one truly dedicated neonatal ventilator, and that's another story. So, having run afoul of our early efforts in conventional mechanical ventilation, we've reverted to pressure-controlled or pressure-limited ventilation, which in its basic functionality is nothing more than a mechanical T-piece. And during the expiratory phase, if you're talking about some sort of an intermittent mandatory ventilation approach, during the expiratory phase, the expiratory valve is open, there's a circuit flow, there's a PEEP valve maintaining some distending pressure, and the patient can breathe in and out of the circuit. And when this ventilator cycles on, the expiratory valve closes, the circuit's pressurized, and gas enters the patient's lungs in proportion to the pressure within the circuit and the compliance of the lungs. And we're not worried about any large leak around the endotracheal tube because there's plenty of fresh gas available to maintain pressure within the circuit. Any excess flow overflows over the pressure limiting valve. And this works, of course, very nicely, except for the problem that once compliance changes, the volume delivered to the patient's lungs will change at any given pressure. We've put up with that because, in part, because we were convinced that pressure is the important factor in lung injury. Turns out that's not true. And because with the uncuffed endotracheal tubes, we found it very easy to ventilate despite large leak around the endotracheal tube. Now we know better. So I want to make the point that volume-targeted ventilation that we employ in neonates is not the same thing as volume-controlled ventilation. Volume, as I showed you, really directly controls the volume injected into the ventilator circuit, does not directly control what gets into the patient's lungs. Volume-targeted ventilation, such as volume guarantee and various iterations of it with other manufacturers, volume-targeted ventilation is really pressure-controlled ventilation with volume targeting, with automated adjustment of inflation pressure to deliver set tidal volume. So this is another way of looking at the differences. There are differences in terms of the gas flow. With pressure-controlled ventilation, again, we set the pressure, and that pressure results in a certain flow, and that flow results in certain tidal volume. And again, when compliance changes, that delivered volume will change. With volume-controlled ventilation, there is a continuous flow of gas into the circuit until the set tidal volume is delivered. and pressure rises passively, reaching peak just before expiration begins. There is, therefore, this is the dependent variable. There's some pressure limit usually set at 45 or some. So it's a different gas flow pattern. And what we're using in babies is not volume controlled ventilation, but volume targeted ventilation, which is pressure controlled ventilation with automated adjustment. And this is the basic algorithm that pretty much everyone now uses. It started off in different areas, but it's pretty much gravitated toward a relatively uniform approach, which is that whatever initial pressure is delivered generates a tidal volume, and that tidal volume is compared to the target. That target is compared, and depending whether the tidal volume as measured is less than target, more than target, or within a few percentage point, the inflation pressure will be adjusted up, down, or kept the same. And that's a continuous feedback mechanism, adjusting more or less breath to breath, but with some constraints so that you don't overshoot. But that's essentially how it works. So it may take a few cycles when there's a large change in compliance to return to the target value. And I just want to take a moment to contrast volume targeted ventilation to other approaches such as NAVA or proportional assist ventilation, which take diametrically opposite approaches. NAVA has become rather popular in the United States. I don't know how excited people are about it in Canada, but NAVA essentially looks at the electrical activity of the diaphragm, which represents the patient's respiratory effort, and delivers pressure in proportion to the patient's effort. As one company rep explained it to me years ago, it's like power steering. The patient's in control. We're just facilitating what the patient's trying to do. In other words, it assumes mature respiratory control. And what I said to the gentleman was, yeah, but when you're talking about 25, 23-week preterm infant, the driver is blind and drunk. They have immature respiratory control. Their respiratory effort's highly variable. So volume targeted ventilation takes the opposite approach, as opposed to the positive feedback in engineering. The feedback, the more pressure, the more effort by the baby, the more pressure is delivered. With volume targeted ventilation, it's a negative feedback. So if the patient is generating very little effort measured by the electrical activity, more pressure is generated by the ventilator, with the goal of maintaining a stable tidal volume. And when the patient breathes vigorously, the ventilator backs off to avoid excessively large tidal volumes. And, our preterm babies tend to have this periodic breathing pattern. They have brief pauses into space with often quite vigorous respiratory effort. And when stimulated, they can generate quite dramatic inspiratory activity. And I worry about the positive feedback that will amplify these sorts of differences. And in fact, here's an example of from a publication by one of the inventors of this concept of NAVA. I love NAVA in older subjects, but in preemies, I worry about it. So here's a preemie who has initially rather weak respiratory effort, hypoventilating, and getting very little assistance from the ventilator. Then a bit more vigorous respiratory effort, getting proportionately more support from the ventilator. Then another period of hypoventilation, brief apnea, mimicked very closely by the ventilator. And then now he's waking up and generating quite large, resulting in a peak pressure of close to 40 centimeters briefly, and then it sort of continues. And so I think it remains to be seen whether this is a very good idea. These babies, and I've watched babies and what tidal volumes they generate for many years. And when somebody comes in and touches the baby, they can generate rather dramatic inspiratory effort. And so, yes, of course, you can put some constraints, you can put some limits, but people don't always set their limits and alarms appropriately. So I worry, is all I will tell you. Now, back to volume-targeted ventilation, which is an approach designed specifically for preterm infants. And these are the benefits that have been demonstrated. And I showed you the meta-analysis earlier. It does maintain a relatively stable tidal volume. There are fluctuations, and the fluctuations are the result of the contribution that the infant makes to the transpulmonary pressure. Remember that with synchronized ventilation, the baby and the machine are working together, generating, pulling, and pushing in the same direction. But most importantly, maintaining a stable tidal volume prevents overdistension, prevents and hypocapnia when things happen that result in improved lung compliance, such as surfactant administration, lung volume recruitment, clearance of lung fluid, and the like. And this can happen quite rapidly, typically soon after intubation. There is also the concept of automatic weaning. Volume guarantee does not wait for the next blood gas to lower the pressure. It does not wait for morning rounds. It's not afraid that the professor will yell at it for making the wrong decision. It does what it's programmed to do and therefore results in more rapid weaning from mechanical ventilation. And then it compensates for that variable respiratory drive that I showed you, that periodic breathing is mitigated by this negative feedback approach. So controlling the tidal volume is important, but that's not enough in and of itself. The full benefits will not be achieved without making sure that that tidal volume is evenly distributed throughout an open lung. And you might be puzzled as to what that exactly means, so let me clarify. I'm talking about volutrauma, or atelectrauma rather, of which volutrauma component. When you have baby with severe RDS, looking at that radiograph in the right lower corner, it looks pretty uniform. We think of RDS as a uniform lung disease, but it really isn't. There are gravity-dependent regional differences, and much of the atelectasis is concentrated posteriorly, with aerated lung anteriorly. And this is shown graphically here. And we know that, in fact, in the alectatic portion of the lung, there's surfactant inactivation, and the longer this persists, the more dramatic the differences might be. There are shear forces at the boundary between aerated and unaerated lung. There are areas of the lung that are inflating and deflating completely with unstable alveoli in this region. And then perhaps there is a portion anteriorly that is remaining open throughout the respiratory cycle. But the issue here is that if you are going to inject a certain volume of gas into a lung that looks like this, the vast majority of that tidal volume will enter the already aerated portion of the lung. This is based on Laplace's law, which, as you recall, tells you that the pressure needed to distend a small radius alveolus is much higher than the pressure needed to distend one that has a larger. The pressure is related to, inversely related to radius. So the pressure needed to overexpand this portion of the lung is less than the pressure needed to recruit this portion of the lung. And therefore, if you persist in ventilating a lung that looks like this with a tidal volume of 5 ml per kilo, and only 1/3 of the alveoli are absorbing that tidal volume, you are certain to get volutrauma. So atelectrauma is a complex process, but overexpansion of the non-dependent portion of the lung is in fact an important component. This was actually documented many years ago, again in an animal study, where they looked at some histologic changes, composite lung injury score, hyaline membrane score, and what you see here with gentle ventilation, there was no lung injury, great. But with more aggressive, more injurious ventilation in this lung lavage model, the anterior portions of the lung bore the brunt of the lung injury, as predicted from that cartoon that I showed you a moment ago. They looked at a variety of cytokines as well. And again, there was more of a rise even with gentle ventilation, but clearly there's more injury occurring in the non-dependent portion of the lung. Volume is all going. So what do we need to do? We need to somehow get the lung expanded, get it from this relatively low volume state through a series of increases. Typically, this is done by increasing mean airway pressure with high frequency. It's easy to do. It's equally easy to do with conventional ventilation, actually, by increasing PEEP typically. But you also, of course, need peak pressure sufficient to reach the critical opening pressure of the collapsed alveoli. And inevitably, you're going to go through a period of overexpansion as you go up from the poorly expanded area over here. You stepwise increase your mean airway pressure, lung volume increases. Transiently, the more compliant portions of the lung will overexpand. And we need to remember that we don't want to stay over here. It takes more pressure to pop open the allectatic portion of the lung than it takes to maintain that volume once the alveoli have become inflated. And now with their larger radius, require less pressure to maintain that lung volume. That's the hysteresis of the pressure volume loop. And you try to find the sweet spot, the lower inflection point of the pressure volume relationship, the critical closing pressure, right? So you need to reach the critical opening pressure of the collapsed alveoli. Once you open them, they become more compliant, and you slide it down to a more optimal portion of the pressure volume relationship. So distending pressure and expiratory pressure in particular is critical. Here's another example of how PEEP is lung protective. So really, I'm talking about two important components. One is controlling the tidal volume. The other is maintaining alveolar stability. The injured lung, especially the surfactant deficient lung, is prone to alveolar collapse at end exhalation. And in this study, again, these are not all new data. We've known this for a long time. The investigators used a fancy microscope to look at the subpleural alveoli, and they were able to look throughout the respiratory cycle, and they compared inspiration and expiratory. So the delta here is the difference between inspiration and expiration. Okay, so this will explain what's going on the next slide. So this is model, so surfactant depleted lungs, lots of atelectasis, very few aerated alveoli. That's on the vertical axis is number of alveoli visible per high power field. Not much change between inflation and deflation because they're all collapsed throughout the cycle. Then with the recruitment maneuver, there's a very nice increase in the number of open alveoli and very little change during the respiratory cycle. So here they're ventilating with the during an inflation maneuver, so very high distending pressure and expiratory pressure. Then following the recruitment maneuver, they drop to normal ventilation with a PEEP of only 5 centimeters of water. And what you now see is that the number of open alveoli during inflation is already much less than it was during the recruitment maneuver. And more importantly, there is a large difference between inspiratory and expiratory fields, meaning that there's a lot of alveoli that are collapsing at end exhalation with this relatively low end expiratory pressure. So in this model, a PEEP of 10 centimeters, there were much more aerated alveoli during peak inflation, and they remained aerated during the expiratory phase. So this is part of my efforts to combat PEEPophobia. If you're not familiar with the term PEEPophobia, it refers to the irrational fear of using adequate distending airway pressure. Distending pressure is important in limiting lung injury. We know that oscillatory ventilation with an open lung concept is lung protective. It turns out that it may not be so much about frequency, but rather the fact that you're using an open lung approach. And these are some, again, older data from Anton van Kam, who in this lung lavage model demonstrated, again, using very injurious ventilatory approach and looking at a histologic lung injury score, there was a great deal of lung injury going on with high tidal volume, low end expiratory pressure conventional ventilation, much less lung injury with oscillatory ventilation using the open lung approach, in other words, high descending pressure. But interestingly, the same degree seen when they used conventional ventilation rates, but a high enough PEEP to maintain alveolar stability. This PEEP was pretty high. This was totally surfactant deficient animals, but the principle is clear that it's really more critical that the lung remain open, that whether you use high frequency or low frequency. So again, as I said before, I think in Canada, folks are more advanced and use volume targeted ventilation much more than in the United States. It's the penetration throughout the world is rather uneven. The Scandinavians get it. The Australians get it. Half the Italians get it, maybe more now. But there are certainly large pockets in Europe where it's still not penetrated, and large areas of the United States where it really hasn't. So what are the reasons other than inertia? Because inertia, you may or may not know, is the most powerful force in the universe. And I wear this button in my NICU to try to get people to move on from their traditions. So fear of the unknown, inertia are big. And if you're fearful and don't want to change, you can always rationalize that you need more data. Evidence is not perfect. We don't have a large randomized controlled trial that clearly shows differences. The problem is it would be ethically very difficult to conduct one at this point. In the United States, many people don't have a suitable device that's capable of effective tidal volume measurement and therefore volume targeted ventilation. But it turned out when we did a survey a couple of years ago that a lot of people just didn't understand how volume targeted ventilation works and how to use it properly. So one of the concerns was, what about the leak around the endotracheal tube? And that's a fair concern, and it used to be a bigger problem. And it used to be that with the older, for example, with the Babylog 8000 plus, if your endotracheal tube leak was more than about 35%, you really started to get into trouble. And I actually wrote an editorial about that time, about 8 years ago, wondering if we should relook at the concept of using cuffed endotracheal tubes, because now it became so much more important to be able to measure tidal volume accurately. And then along came some new technology that made that unnecessary. But here's an illustration of how the measured tidal volumes will deviate from actual tidal volume delivered during inspiration and expiration. Leaks always more during the inspiratory phase. Of course, it's driven by the peak inflation pressure. So this was the actual delivered tidal volume was about 4.5 ml on this bench model. And then they introduced progressively larger leak going up to beyond 80% on 90% leak. And what you see is as you go up on the leak, you begin to see significant increases in or deviation of the measured tidal volume from the actual tidal volume that was being delivered. Now, in this bench model, they were quite PEEP-phobic. They use a low-end expiratory pressure. If you use a higher-end expiratory pressure, the leakage during the expiratory phase, which is driven by PEEP, will be more. But even with this relatively very low PEEP, you begin to start to see a significant deviation from the actual set tidal volume. And so they proposed a way to calculate the actual delivered tidal volume despite a progressively larger leak around the endotracheal tube. And what you see here, that even up to beyond 60, 70, even 80% a tidal volume with pretty good precision that represents the true tidal volume regardless of what's being measured. So at 80% leak, the exhaled tidal volume was, looks around 2 ml, and the inspiratory tidal volume was way crazy high. But so that's a problem, right? So the clever engineers at Draeger came up with this leak compensation concept, which allows them to give us essentially the true tidal volume that gets into the baby's lungs. So in this example, in this illustration, let's say the inspiratory tidal volume is 6 ml measured here at the flow sensor at the top of the endotracheal tube. And there's a 33% leak. So 2 mLs, 1/3 of that volume leaks out during the inspiratory phase. So only 4 mLs actually gets into the patient's lungs. But there's also leakage during the expiratory phase. So although 4 mLs entered the lungs, 1 mL, 25%, escaped around the endotracheal tube during the expiratory phase. And so the exhaled tidal volume measured at the flow sensor is only 3 mL. So it's under 25% what the patient really experienced. But so using the data that I showed you on the previous slide, they are able to give us this compensated tidal volume. With the Draeger, VN500, they give you an option, and so this was not available on the 8000. It is available in the VN500 and the newer models coming up. You have the option of activating or not activating the leak compensation. I can, for the life of me, not imagine why you would ever not want to activate it. But this is what happens even here with an extreme leak of almost 70%. So this is a 1.5 kilo baby. So the exhaled tidal volume that is being measured is, the exhaled tidal volume that's being measured is 3.5 ml, but the machine actually calculates that the baby is receiving 6.8 ml of tidal volume. This is the calculated value. This is a 1.5 kilo baby, so it's receiving 4.6 ml per kilo tidal volume. And so this is great. But if you did not have the leak compensation activated, the machine would be using this uncorrected value. So it's drifted a little bit from 3.5 to 3.6, but pretty much the same, right? It would be using this value, 2.4 ml per kilo, and it would be cranking the inflation pressure up to try to bring this tidal volume up to your target. So this would be grossly overventilating the baby. So ventilating with a large endotracheal tube leak without leak compensation is one scenario where volume targeted ventilation can get you into trouble and cause overventilation. It is not a problem when you use the leak compensation. It's really cool. All right, we're going to talk about some practical aspects now. And we did a little survey a couple of years ago because I was frustrated by the slow penetration of volume targeted ventilation, especially in the United States, but we included the United States and Canada in this survey. And we wanted to know whether people were using it, if they weren't, why they weren't. And we also wanted to probe their understanding of what the appropriate tidal volumes are. And it turned out that it was that second most informative. But from the comments as to why you're not using it and we allowed freeform, it was obvious that a lot of folks just didn't really know the literature and didn't really understand how to use volume targeted ventilation. So it quote unquote didn't work. And this next few questions and graphs will help us understand why. So I have a few questions for you, for the audience here, and hopefully we can make this work. So these are the polling questions. You have two options. You have a 50% chance of being right, but let's see how you might answer. And I hope that we can make this work. So I can only see my slide, so somebody.
Martin, click the three dots and you will see the polling option. You click the polling, you can see the the polling result.
Three dots. I don't see any dots. Can maybe there was the
last but one.
Maybe I need to. I'm not able to see the polling question.
If you scroll the mouse down, it will open the three dots at the bottom.
Some reason that's not working for me. Maybe it's okay. Well, it's up here. Let's see. All right. Polling. Okay, it was at the top, not at the bottom. I closed it. All right. So, but I still only see the question. I don't see the. I don't see the answers. I get to answer my question, but I don't see the.
So around 70% of the audience answered answer 1, and then 20% answered answer 2.
Okay, so majority of you are correct. That's the good news. It's not a 100%, but it's a majority, and I'll definitely accept that. So when we posed that question and we gave them sort of multiple options, and most people chose 5 per kilo, but the actual correct answer for the really tiny premature baby is more like 6 per kilo. So most of you were correct. Oh, there it is. Now I can see it. Yeah. What happened here? Are we on the next? No. All right. So maybe there's some more votes. Anyway, the bottom line is that indeed the tiny baby needs a larger tidal volume per kilo, which might seem counterintuitive until you realize that it's really about the effect of the instrumental dead space of the flow sensor, and that's seen here. So this is a study we did a number of years ago for babies less than 800 grams. And we looked at what tidal volume was associated with normal PCO2. In other words, when the CO2 was in our target range, what was the tidal volume? And these extremely low birth weight infants here between 700 and 800 grams, the tidal volume was around 5.5 ml per kilo, as you might predict. But when you get to the other end of the extreme, the ridiculously low birth weight infant, that's a copyrighted term, you need more like 6 ml per kilo. And this has to do with the fact that if the baby is 800 grams, the flow sensor dead space is about 0.0 ml regardless. If the baby is 400 grams, the dead space of the flow sensor is still 0.0 ml in absolute terms, but in a per kilo basis, you can appreciate that it's twice as large relatively. And therefore, it requires some degree of compensation. Not as much as you would expect, because there is some admixture between dead space gas and fresh gas, contrary to what conventional physiology teaches us. So the increase is not as large as you would expect if the dead space truly doubled. But there is an effect, a small enough effect, but a meaningful one, so that if you don't recognize that, you may have a problem. There was a paper published out of ago that concluded that volume guarantee did not work in babies of less than 26 weeks. And the problem with that study was that they applied a tidal volume of 4 per kilo for all patients. And guess what? That didn't work for tiny babies. So it's important to keep the physiology in mind. All right, another question. Let's see if we can make it work. Which of the following 2 infants needs a larger tidal volume per kilo to achieve a normal tidal volume? And here we have a same-size baby. One has meconium aspiration, one has RDS. And okay, now I'm seeing something. Okay. So you have a few seconds to ponder this. Most of you should know this pretty quickly. And it will allow us to discuss the answer and why it might be what it is. All right. We'll give folks about 1 minute. It shouldn't take this long, really. Be able to respond pretty quickly. So I think you can probably close the polling because, you know, we're needing decisive. So you can't think about it too long. Just got to make up your mind and make the call. All right. So I don't, what do I have to do to, if I push submit, what happens? Nothing, right? How do I get to see the polling results? Let me see if I can.
Sam, can you publish the results, please, Sam?
Oh, there we are. Oh, let's see. A, B, no answer. Okay, people were pondering. It looks like we have a very much of a split decision here. There was a fair number of folks who didn't quite make up their mind. So, you know, we'll give you maybe a few more seconds for the subsequent questions, but, you know, we got to be decisive. We're intensivists. We can't ponder it all day. Anyway, the correct answer is the baby with meconium aspiration syndrome, and this is why. This is all these questions are based on published literature, so this is not a secret. You see why? Okay, there we go. So we posed that similar question. All right, this one was bigger baby, but same concept. And for some reason, everybody thought that every baby requires the same tidal volume of 5 per kilo. That isn't true. Correct answer, once more here, is 6 ml per kilo, but for different reasons. The tiny baby, there was an increase in essentially anatomical dead space. Here it's an increase in physiologic or alveolar dead space. Babies with meconium aspiration, and the babies we looked at were the ones with the classic picture of air trapping, hyperexpansion. All of those things will increase your wasted ventilation, your physiologic dead space. And so this is what our data published 5 years ago now showed when we looked at a bunch of babies with classic meconium aspiration syndrome. And what we demonstrated was that they required a tidal volume of a bit over 6 ml per kilo compared to a little less than 5 per kilo in similar sized babies, late preterm babies with more homogeneous lung disease. So highly significant difference, same sort of approach when the CO2 is normal. What is the tidal volume? These babies were also quite tachypnic, so their minute ventilation larger, much higher than the minute ventilation in the control population, yet their PCO2 was virtually identical. So this clearly tells us that this is about wasted ventilation, increased physiologic dead space. So again, if you don't recognize that the disease process that you're treating has a different pathophysiology and don't pick the right tidal volume, volume-targeted ventilation might seem like, yeah, this doesn't really work. It's not that it doesn't work, it's that sometimes we don't know how to make it work, which is why I'm belaboring this. So despite a 42% higher minute ventilation, in these meconium aspiration babies, their PCO2 was the same, so greatly increased alveolar dead space. All right, another question. Number 3, which of the following two infants needs a larger tidal volume per kilo to achieve normal PCO? Gosh, we're running a little late. We're going to have to speed it up. So we have a tiny baby who is 2 days old and a tiny baby who is now 3 weeks old. Which one will need a larger tidal volume per kilo? And please vote. Please make up your mind quick. You either know the answer or you don't. If you don't, I will tell you what the answer is. So I'll give it about 30 seconds and then we'll wrap it up. We've got to be decisive here. The point is to get to the explanation. So. All right, almost there. Last chance. Speak now or forever hold your peace. All right. So we have yet again a split decision. So I'm glad I'm not wasting everybody's time. If everybody got the right answer right off the bat, then we could wrap it up. But we have something to talk about. So the correct answer is B. It's the older baby that needs a larger tidal volume, and this is why. Let me see if I can make this go away and move on. The audience in the survey actually got this one right for the most part, although way too many people still gave the same answer for everybody. So we published on this a number of years ago again, and this was the same group of babies, less than 800 grams. That remained, those who remained on mechanical ventilation for up to 3 weeks, so a subset, a minority, despite allowing their PCO into the mid-50s, with permissive hypercapnia, these babies were requiring progressively higher tidal volume. And this has to do with the evolution of chronic lung disease, which again results in increased alveolar dead space, as you some air trapping and heterogeneous inflation. You probably also have increased anatomical dead space because you have the trachea stretches. When you ventilate at a rate of 50 per minute, that translates to 75,000 inflations in 24 hours, over 1 million in a week, and it stretches the trachea, so you have a larger anatomical dead space and larger alveolar dead space. So to wrap it up, compliance changes most rapidly soon after birth. So it's best to start volume targeted ventilation very soon after intubation. Most babies will do well with the tidal volume somewhere in this range. We tend to start on the lower end, but if it's a tiny baby, if it's a baby with meconium aspiration, if it's an older baby, and really bad old BPD babies may need a tidal volume of 8, even 10 ml per kilo. So those babies I showed you were only 3 weeks old, not yet severe established chronic lung disease. So appropriate tidal volume choice is the most important decision. We showed that you should use underlying synchronized mode that supports every breath, and pay attention to not just the pressure limit but the actual working pressure, and it will work quite well for you. We have one more question to wrap it up, and that's a quick, simple one. Again, weaning from pressure control ventilation is done by lowering the pressure. Weaning from volume targeted ventilation is accomplished by progressively lowering the tidal volume target to about 3 ml per kilo. Is that true or is that false? Again, a fairly straightforward question. You either know this or you don't. It's not a lengthy calculation. But I will tell you that this issue causes a lot of problems. All right, we're almost there. Last chance to make a decision. All right, let's see what we got. Can you publish the results, please? There we go. Most of you got that one right. There's still too many absentees. Maybe for some reason they don't actually have the ability to vote. That's possible, so we won't hold it against them. Most of you were right. You don't lower the tidal volume target. In fact, as you saw in some babies, you have to go up. The pressure needed to deliver the same tidal volume that goes down. That's how PG weans. And when the pressure gets low enough, you can extubate the baby. And that's pretty straightforward, but people often do make this mistake and try to wean the tidal volume too much. Clearly, we know that we need to make sure the baby has a respiratory drive, but if you push them too much, you're going to get into trouble. I'm not going to spend a lot of I'm going to skip over it because we are kind of out of time. But if you lower the pressure too much and make the baby do all the work, this is what you're going to see. Here's a scenario where the baby's tidal volume setting is less than what this particular baby needs. Baby generates a tidal volume with their own respiratory effort greater than the set tidal volume. Pressure comes down, down, down until it becomes essentially PEEP. And so this baby is getting no help from the ventilator. You can see he's pretty tachypnic. And if you look at the baby, he's probably retracting and has a climbing oxygen requirement. And that's a way to make them fail weaning. So you don't wean the target. The weaning occurs automatically, and that's summarized here. You want to be sort of on the lower end of what this sort of baby ought to need. But as long as you have a pH that is low enough for the baby to have a respiratory drive, you will be fine. You don't want to do this. And when the pressures are low enough and you can have your own set of numbers, then you're able to get the baby off. And so, obviously, package deal, BPD prevention starts in the delivery room, but volu-trauma and atelectrauma are the two big issues that we can work on. We can actively limit by optimal ventilator management. You need to appreciate the physiologic differences. One size does not fit all. And you have to think about what's really going on and how to address it specifically based on the underlying pathophysiology. And you need to understand the capabilities of your device. And that's all I have. And that slide is in Hungarian. Okay, never mind. Not Hungarian, Turkish. So thank you very much. That's all I have. How do we move on to?
Thank you, Martin. Ruben?
Yeah. I don't see the questions yet, but I have a question. First of all, thank you very much, Dr. Keszle, for a very clear and comprehensive presentation on volume-targeted ventilation. My question refers to if you can briefly explain the main differences, mostly advantages and disadvantages of PSV volume-targeted and AC volume-targeted ventilation, and when would you indicate one or the other?
That's a great question. I think in most babies, we should probably be using pressure support, flow-cycled mode, which automatically adjusts the inspiratory time to be just right. The exception to that are the really tiny babies with very low lung compliance early on, translating into extremely short time constants. When you try to do pressure support on a 24-week, 700-gram baby, actual inspiratory time is going to be 0.25, 0.22 seconds, which may be too short. They tend to get tachypnic. There tends to be a circuit recoil. So I avoid pressure support in the first few days, or when you can tell from the waveforms that the time constants are really, really short. Once airway resistance starts to go up, once compliance starts to improve and time constants get longer, then pressure support, I think, is the optimal approach. People need to remember that with pressure support, the I time is typically quite short, and that you need to use enough end expiratory pressure to make sure that you're maintaining optimal lung inflation. I find that there are times where people switch from assist control to pressure support, shorten the I time, drop the mean airway pressure, and then the baby starts to backslide, developing microallodysis.
There is a question from the audience here. The question says, does you have an upper limit with significant endotracheal tube leak when you consider a tube change to a larger endotracheal tube, especially due to concerns of losing PEEP and inadequate ventilation?
Yeah, that's a very important question. Actually, with loss of PEEP and inadequate ventilation is rarely a problem, even with a large leak. It's really the ability to accurately measure tidal volume that's my biggest concern. So it depends. The answer to your question depends on what ventilator you have. If you have one that, if you have the VN500, and I'm not sure if the Leone can do the same thing. I know you have those in Canada. If you have a ventilator that has this leak compensation function, then it's not much of a problem up until leaks of certainly 50-60%. If the leak's any larger than that consistently, then I would just change the tube because it's easier for the baby to breathe spontaneously through a larger endotracheal tube. And as we wean and want the baby to be doing more work, I would want them to have an easier time. But in terms of accurate tidal volume regulation, at least with the VN500, you can ignore leaks that are moderately large, and you will not autocycle. You will not have problem with breath termination, because the leak adaptation also works very well on that. If you don't have that effective leak compensation, then I would upsize the tube if the leak is more than 40%. And we used to do that for a long time until the new ventilator came out, and you develop the technique where you insert the laryngoscope with the old tube still in place, visualize suction, whatever you need to do, then pull the old tube, put in the new tube. You miss one inflation, one ventilator cycle. So it's really fairly easy to do, and if your ventilator does not have that leak compensation, just change the tube.
Okay, I see another question from Turkey here. Apparently, this group of physicians don't have a good experience with using VG in babies under 26 weeks. And I think the question they have is that what will be the indication for switching from VG to high frequency? So at one point, would you say the baby's failing VG and needs to be switched to a different mode of ventilation, in this case, high frequency?
So I would argue that what's failing usually is the physician, not the machine. But certainly, if a baby has really severe lung disease and is requiring relatively high peak pressures to achieve adequate tidal volume and adequate ventilation, then switching to high frequency is probably reasonable. But in almost all situations, you can get that lung recruited and make it more compliant. And in terms of not having a good experience, usually translates into not selecting the appropriate tidal volume targets. And if you have those tiny babies and you're trying to ventilate them with 4.5 per kilo tidal volume, it's indeed going to not be a good experience. That said, there certainly are. It's certainly reasonable to consider high frequency ventilation. I'm very excited about the opportunity to use volume guarantee with high frequency ventilation, which is now available on I know a couple of different devices. And so you can have the cake and eat it, so to speak. You can have volume guarantee and high frequency ventilation all in one. And we just finished a study a couple of years ago here in the United States, trying to get approval for the high frequency option in the US, and hopefully that's going to happen. But the FDA is too big right now to pay attention to anything else. So you don't have to choose between volume guarantee and high frequency. You can use both, and it works like a charm.
Gani or Yasser, do you have any other questions? I don't see questions on my side. So I don't know if you have a question or you see more questions from the audience.
I think there is a technical difficulty that the audience are typing questions. I'm not sure how, like, it is appearing to my screen. I cannot answer, but I don't know why you are not able to see. There are many questions already asked. Like, I'm not sure why you are not able to see. But I'm sorry for the technical issue. And these questions we will copy and we will post it as in our website as an answer. Yasser, if you are able to copy all these questions, can you please copy? Because I don't have that facility. I can just see. And we can ask Martin to answer offline and we can post it on the website.
Yes, Gani, I think I can see some questions, but probably because of the time, we are running out of time. So probably we can communicate with Martin by email, and probably we'll announce soon for the workshop in August. So it'll be like more a chance to communicate directly and get more experience on the art of mechanical ventilation and respiratory physiology during the workshop. So you will get an email soon about the announcement. Thank you. Thank you, Martin. Thank you, Ruben. Thank you, everyone, for joining us today. We got almost close to 600 participants today. That's really a record.
Wow. Okay, thank you very much.
Thank you.
And the answers will be posted in the same web page as the announcement what it came and on our web page. Shortly we